I mean, I think it's critical. I think medication adherence, obviously taking medication is a core of managing a chronic disease. And it would appear on the surface it's a fairly simple thing to do. You know, you have a script, you fill it, you get some medications, it tells you how to take them, and then you take them. But obviously the patients who most need to take those medications are least able to take them because they have barriers to getting the medication in the first place, and then in terms of taking them, they're really confusing and they're getting medication from lots of different sources. And I think the medication adherence problems are emblematic of coordination problems in the health system at large. And I think as far as we believe, that care coordination problem is the one that is the interesting one to work on, and medication is a part of it. So we believe you have to not just coordinate the medication, you've got to coordinate visits, you've got to learn about the condition, you've got to test the understanding of that learning, screen for secondary complications of the condition, and manage risk factors underlying the specific disease. And that is the care coordination task, and medication is one part of it, and we have to think about how to do that in the context of people's lives over long periods of time. And for large populations. So it's really simple. So that's the challenge, right? And like the consequences of not doing that are that people, and millions of people across the country, across the world, are having events, secondary events. So they would have, for example, hypertension and then have a heart attack, or diabetes and have a heart attack, or diabetes and have a neuropathy or a complication of diabetes. And those are theoretically preventable if we could coordinate care better. And I say theoretically preventable, it's been proven in situations where you can coordinate care better that over a long period of time you have a lower rate of complications. And our work at WellFrame is to try and take what we know works and bring it to more people by using a mixture of technology and human care, the optimal mix, not technology alone or human care alone, but technology in the context of a relationship to try and most optimally leverage the care coordination resources, be that a disease manager or a care manager or a diabetes educator or even a peer coach. How can we get them to manage as many patients as possible? And we do that through a mixture of protocolizing all the good stuff that they're doing and delivering it to patients as a daily multimedia checklist on their cell phones, and based on a patient's interaction with that, we collect that information and provide that in a filtered form, not in a stream of consciousness form, in a prioritized form to a clinician who can respond to patients according to their degree of acuity. And they can do that every day if they want to, or they can do that once every week. But that's much better in terms of coordinating care than once every 3 months, which unfortunately is what we have to do in practice at the moment.